Hello and welcome to Race, Health, and COVID-19, part of University of Iowa Center for Human Rights series on racial equity and human rights. My name is Colleen Opel, and I am the program coordinator at the UI Center for Human Rights. In this hour, we bring together scholars and practitioners to inform us how health and access to healthcare is shaped by the same institutional racism that impacts other areas of our society. These speakers will also address how these built-in health barriers lead to widespread consequences for marginalized populations, including Latinx, Black, and Native Americans. Our speakers today are Dean Kevin Washburn from the University of Iowa College of Law, and Dr. Claudia Corwin, Assistant Professor of Internal Medicine at the University of Iowa, and Dr. Nafisa Egbone, the Black Hawk County Health Department Director. To see a recording of this and previous events, please visit our website at uichr.org/racial-equity. Please also consider donating to support our work, including programs like this. And don't miss our next two webinars in the series. See if I can pull those up here. The next one is Race and International Human Rights. That is on Wednesday, July 29th, noon to 1. And after that, on Wednesday, August 5th, moving forward on Native American rights. Throughout the webinar, please submit your questions through the Q&A box at the bottom of your screen, and we will hold those till the end at the Q&A period. And now I will turn it over to Dean Washburn.
Great, thank you so much. Let me share my screen and get started here. All right, so I'm here today to talk about COVID-19 in Indian country, and I am largely going to focus on the Navajo Nation because I have done some focused work there in the last few months trying to help the state of New Mexico and the Navajo Nation kind of get a hold of this issue. And so I thought it's what I know best. Navajo is only one of 574 tribes in the United States, but it's an important one. And so I'm going to focus a bit of my talk on that. Let me say that one thing that's really important to tribes in the United States is data sovereignty. And so what you're looking at right here is a screenshot of the web page from the Navajo Epidemiological Center from yesterday. Navajo Epi, it's called. And so they prepare, the Navajo Nation is a government. It's like government, like a federal government or the state government, and they prepare their own data. And so the data that I'm showing you is Navajo's data. The scary thing here is this number, 425 deaths. Let me just tell you a little bit about the Navajo Nation. The Navajos have occupied the place where they are since time immemorial, since long before there were Europeans on this continent for sure. And one of the key moments in the Navajo history was the Long Walk. In 1864, a man by the name of Kit Carson, working for the United States Army, forced the Navajo to walk to Bosque Redondo, an internment camp in eastern New Mexico, which was 250 to 450 miles away from their homes, depending on where they lived on the Navajo reservation. Carson did that by burning villages and crops and killing livestock, and he destroyed the water supplies as well. And so he marched roughly 10,000 Navajo people out of their homes over to Bosque Redondo, and a couple of hundred people died on the journey, fewer than 425. A lot of tribes have a Trail of Tears type experience in their histories, and this was Navajo's, the Long Walk it's called. And perhaps it's hyperbole, but this 425, like I said, was more than they lost on the Long Walk. The tragedy here today for the Navajos is those 425 people, a lot of them are elders. And when they die, they take part of the language and the culture with them. At the Navajo Nation, there are a lot of people my age that don't speak Navajo and younger, but a lot of the elders and a lot of the very young people, they've got children that are learning Navajo from the elders. But if you lose a lot of elders, it's really devastating to the whole tribal culture. And that's what I'm worried about for Navajo. One of the things I'm worried about for Navajo. And you see the weekend curfew. I'll talk a little bit more about that later. Here is the Navajo Nation. This is just a map of the Navajo Nation. It's in the Four Corners region. Those are the so-called Four Corners where 4 states come together, and the Four Corners point is actually on the Navajo reservation. There's a site there you can go visit. And Monument Valley, you've seen pictures of Monument Valley. If you're alive in the United States, you've seen pictures of Monument Valley, and it's located right in here. Between Navajo, Arizona, and Utah within the Navajo reservation, so along in this area. This is a big reservation. It's roughly this 27,000 square miles, roughly the same size as the state of West Virginia. So the Navajo Nation, this reservation, is bigger than 13 of the American states. It's huge. And it's sui generis. There, again, of 574 tribes, there are none that are just like Navajo. Navajo is the biggest and in many ways fairly unique. Part of the challenge with Navajo is that this is rural area. This is all very rural. Window Rock is one of the bigger cities. Tuba City is another larger city on the reservation, and then Shiprock is over in this area. But those are small cities, and most people live scattered around the reservation. They live far apart from one another. And I'm just going to read you a paragraph from the New England Journal of Medicine from a doctor that wrote in late April about COVID-19. And she was manning a fever clinic, a parking lot where they were having people come in and test. She said, "Cars pull into the lot and I approach them in personal protective equipment. I hear a driver say matter-of-factly, 'I know we're supposed to be 6 feet apart, but this was the only way to manage today. There are 7 people in the car and they have driven 50 miles to get here. The driver is in charge of the family and is ill. One of the passengers diagnosed with COVID-19 several days ago has been getting increasingly short of breath. A few others came to be tested. Young children and a grandmother couldn't be safely left at home, so they came along too. My colleague whisks the sickest patient away for admission to the hospital. I reach through the window and push a viral swab deep into the grandma's nostril, making her cough, while a surge of wind shoves the bottom of my gown up through the open window into the car. I picture the virus particles bouncing on my gown, swirling in the wind eddies. I marvel at how far this virus has traveled to get here." That's life for a doctor on the Navajo reservation, working with Navajo people who live scattered about in scattered hogans all over this 27,000 square miles. It's quite a challenge. So what's the effect of that challenge? Well, here's the, based on the Navajo data, here's the infection rates, and this is CDC data as well, but the infection rates per 100,000 people. You can see in New York City, which is, was the hardest hit place so far. Florida is catching quickly, I believe, and some other states, Arizona, but Florida has been the worst, and it's 2,600. Navajo is nearly twice that infection rate, twice New York City. So that's and interestingly, even though they're scattered across this very large area. So that's a problem. It's really, really bad on the Navajo reservation right now. So let's bring in the more of the racial equities here. And this is a hospitalization rates per 100,000 population by age and race and ethnicity. And you can see for whites, this is the white categories from the far right side, and whites, this is scaled to white people. So the whites are considered 1 of the ratio. Everything is scaled to them at 1. So Asians are 2.1 at 0 to 17, ages 0 to 17. Asians are two times more likely than whites to be hospitalized. Hispanics are 8 times more likely than whites to be hospitalized per 100,000. And that's at age 0 to 17. If you move to age 18 to 49, it's the American Indians that have the highest rate, which is 10.6 times whites. But blacks are 5.7 and Hispanics are 9.4 times whites in essence. So move up to middle age, my age, 50 to 64, Native Americans are 7.6 times the white hospitalization rate at 491 per 100,000. And and African Americans are 5.5 times what whites are. At 65 plus, elderly people, it's the black population that has it worst in the hospitalization rates, and they are at 3.8 the white population, 3.8 times the white population. And here's the total numbers are down here at the bottom, and in the next slide I will show you what those look like in a bar chart. So here's if you add all of those ages together, the associated hospitalization rates by age and ethnicity are like this. Much higher for American Indians and Alaska Natives, Blacks, and Hispanics, Latinx people. So that's the racial equity. This disease, as everybody knows, is striking some populations far worse than it's striking others, and at all ages, frankly. It's just different as to which ages it's striking. So what are we doing to address this? In the Navajo Nation and in other tribes across the country, they are using tribal sovereignty. That's one of the things that they're trying to do. And I'm going to talk a little bit more about that in a minute, but let me just talk about what some of the problems are. I mean, what's caused these? Why is it that the numbers are so bad for American Indians? And the problem is, one of them is that at Navajo and a lot of American Indian reservations, there's no indoor plumbing. So American Indian households are 3.7 times as likely to lack complete indoor plumbing than all other households in the United States. And when I say households, I mean families. American Indian families are 3.7 times more likely to lack indoor plumbing, in other words. And you can see why that's a problem. I don't know about you all, but I took the guidance to heart that I've washed my hands for 20 seconds, and I'll be honest, I turn on the hot water and I tend to leave it running while I'm lathering up my hands. Do you do that? If you do that, that's called privilege. Just know that that's what that is. You're very fortunate if you're able to do that, because a lot of people don't have water. They have to truck their water to their homes, and they can't use water like that. Remember that there are also 500 uranium mines on the Navajo reservation, all of which are closed, but most of which have not been remediated yet. And so they are polluting the groundwater, and so you can't just sink a well. You've got to drive to a place where you can get clean water. The other health issues that are involved are that, tribes went through big changes from agricultural practices or hunter and gathering cultures to, how they live today. And accordingly, they have higher rates of heart disease, diabetes, asthma, and high blood pressure. And that's been taken a real toll on those communities. They've just got underlying issues. Also, a problem is that for Native American people, healthcare is a federal responsibility. And I don't know whichever state you live in, you probably have an opinion about how well your own state is leading in this pandemic. But the federal government's had its challenges as well. And so the Indian Health Service and federal authorities are at work on Indian reservations, and they've had some serious challenges and have not always been effective. So that's where tribes come in. Tribes have been doing a lot to try to attend to their issues. And here is what that looks like in practice. They've got roadway checkpoints. They've closed tribal borders. They've instituted curfews. And this is what it looks like, driving on highways near the Navajo reservation or in other reservations right now where they've sought to close those borders. You see this banner that I showed you from the Navajo EPI website. Navajo is really taken this seriously. They don't have a weekday curfew because people have to work. It's an impoverished reservation. But the Navajo president has imposed a weekend curfew. I must be going on 12 or 16 weeks by now, every Friday evening at 8 p.m. that lasts until 5 a.m. on Monday morning, every weekend. So they have really taken strong action to address the pandemic at Navajo and similarly at other Indian reservations. Interestingly, though, they've gotten a lot of heat for that. In South Dakota, Governor Kristi Noem threatened to sue tribes for introducing checkpoints on the reservations in South Dakota. And sheriff's offices, even in the Navajo area in New Mexico, have been quite critical of these checkpoints. because they are closing public highways, or at least causing checkpoints on public highways. And some of the neighboring jurisdictions are sort of jealous of that authority being exercised in that way. Governor Michelle Lujan Grisham has not been critical. She's been very supportive of the Navajo Nation on the New Mexico side, and has been working carefully with them to try to make sure those, Navajo sovereignty is protected, but Navajo public health is also protected. And frankly, there's a success story. And here's your success story. These are new reported cases by day on the Navajo Nation. You'll recall here in Iowa, we had a peak along in here, and that was bad. But the peaks along in here have been higher. So the peaks in the last there were a couple of weeks that were peaked much higher than back in April in Iowa, in this area, at least and certainly in Johnson County, where the University of Iowa is. So this is a pretty good look. The Navajo are doing a good job of addressing their problems. They've driven down the new reported cases. They're doing a lot more testing, but the new reported cases have gone down on the Navajo reservation. And so they've been doing a good job of addressing this problem. So that's what the lesson here, to my mind, is that sovereignty works, that tribes need to be able to address these issues themselves, and they're doing a good job of it when they have the tools to do so, and now that they've really gotten engaged. One of the long-term problems, and this is my last slide, but one of the long-term problems here is we really don't have great data for Indian reservations. So from the 2010 census, the self-response rate for people in the US, all US households, people filling out those forms and sending them into the US Census Bureau, was 74%. It was only 29.5% on the Navajo Nation, on the Navajo reservation. And so at least 5% of Native people nationwide were undercounted, is what estimates show. In 2020, currently, we've got a 62% self-response rate for census data, and only 7.1% during COVID-19 on the Navajo Nation. So these data are not perfect, and data is a consistent problem. We have a difficult time even measuring tribal data in the United States. I'm going to stop there, and I'm going to turn it over to Dr. Claudia Corwin from the Department of Internal Medicine at the University of Iowa. Claudia?
All right. Over the next few minutes, I'm going to speak about how many of our Latino populations are experiencing the pandemic, and try and connect that to the overall context of health disparities. I'll also talk about some of Iowa's most invisible workers, the migrant farm worker. And hopefully, my report will complement Dean Washburn's talk and Dr. Abonnier's talk. And I am going to be speaking quickly, so forgive me. I do want to, okay, there we go. All right, so I'm not going to repeat these objectives, but so starting off with data isn't usually the most impactful way to start a talk. But in this case, as Dean Washburn showed, the data is so stark and so alarming that I think this really is an exception. Many of you probably saw the recent piece in the New York Times where they reported on data that they actually obtained from the CDC by filing a Freedom of Information Act lawsuit, really to expedite data release. They reported on 640,000 cases in 1,000 counties were analyzed. The CDC had released information on nearly 1.5 million cases. However, the Times asked for information about race, ethnicity, and county of each positive person. So in some, 1,000 counties were analyzed. There are still lots of data gaps, with more than half the cases missing race and ethnicity information. Just the same, this data is alarming, and it is relatively comprehensive. And you can see that Black and Latino people are 2 times more likely to die. This map shows counties with more than 5,000 Latino residents and that have data for both white and Latino residents. This does not show June or July data. And again, look at the orange areas on the map of Iowa, where Latinos have 2 to 4 times the number of cases compared with the white population. Now take a look at these 2 counties in Iowa. Take a look at the orange bars. It's really quite striking. Both counties have meatpacking plants with outbreaks, and of course we all know how the issues surrounding whether or not and when plants closed to control outbreaks. And of note, across the country, 43% of Black and Latino workers are employed in service or production jobs that cannot be done from home, compared to 25% of white workers. Just think about how this sets people up for this global and national public health emergency. The data is still far from perfect. However, there are important patterns that are emerging, and the data that Dean Washburn showed was excellent regarding age. Here we see one of the first large-scale stratifications by age, showing that Latino people between ages 40 to 59 have been infected 5 times the rate of white people in the same age group. More than 25% of Latinos that died were younger than 60, compared to 6% in the white population. On this graph, the white numbers reflect relatively high elder counts and many fewer elders many more in the younger age groups in the Black and Latino populations. This is distinctly different. This graph shows how many more young people are infected in the Latino and Black populations. Look at the shape of the graph, with the wider bands at the top in the Latino and Black populations. So we looked at a bit of data from the New York Times, albeit a lay source, but there's supporting data from the CDC via the MWR. This race and ethnicity specific data was obtained through supplementary data collection and not based solely on the usual case-based surveillance that the CDC usually uses and reports. They look for information from medical charts and death certificates and from state and territorial agencies, as well as 56 local public health departments. This data had more than 90% completeness for age and race ethnicity. However, even with the New York Times data and the recent MWR report, there are big data gaps with respect to race and ethnicity. And this brings up that at the core of our awareness about and our knowledge regarding health disparities is the problem of gaps in our data about the ethnicity and race. It just has not been enough of a priority at a national level. And we know that data gaps hide disparity, data gaps prevent public awareness, data gaps hinder policy development, and essentially, data gaps promote disparities. So I'm going to pivot now, and I'm going to talk about the migrant farm worker, and as an example of a Latino population that is suffering and having a disproportionate experience during the pandemic. There are 7,000 previously invisible, now essential migrant workers arriving in this state as we speak. Most of our workers will travel from Texas or Mexico, most traveling in crowded buses for up to 3 days in unventilated, unair-conditioned buses. And while working in Iowa farms, these workers will likely form tight communities, usually residing in crowded conditions, crowded quarters, traveling to the fields in multi-person vehicles every day, 2 or 3 times per day, and eating in communal settings. Our migrant workers are a highly vulnerable group for reasons related to the entire spectrum of social determinants of health. We know from our Proteus clinic data that many workers arrive with chronic medical conditions that add risk to COVID infection. So a bit about Proteus. I'm going to do this briefly. Proteus is a HRSA-funded, federally qualified mobile community health center. And for the sake of time, I won't go into a lot of detail, but suffice it to say that they have been serving immigrant and migrant Latino populations for the past 30 years as primarily a primary care clinic in Iowa. In Nebraska and Indiana, they also do a lot of job training. So here you see a couple of our clinic settings: a laundry room at a migrant camp, a porch at a house where several people live for the summer. As primary care providers for the farm workers, and due to really our long-term relationships with many growers and employers across the state, we are often or usually the very first to know about an illness or an outbreak among people in a camp across the state. Because of this, we very recently found ourselves mitigating the first COVID migrant farm worker outbreak. There have been others since. Over the past several months with COVID, Proteus had already begun to employ a new model of primary care. Now, first having telemed visits, really telephone visits, followed by face-to-face as needed. Usually following an evening of calls, providers will travel up to 1 to 3 hours away and deliver meals, do an examination, or take a blood sample. Here you can see that we're delivering meds at a road stop. Here we're delivering some supplies at a front door. And here on the way home, before we made our 3-hour trip home, we're spinning down some samples. We borrowed an electrical socket at a local closed Mexican restaurant. Well, one evening, Proteus providers were conducting some telemed visits, and the next day, they did some primary care follow-up with some in-person visits. One worker at the site complained of wrist pain, and we saw on the review of systems form that he reported on the paper a cough. He did not report it verbally, so he was interviewed, and he was a very reluctant historian. He denied all other symptoms. He did report the cough. A COVID test was done on the spot. He was isolated, presumed positive based on his symptom, in a hotel, and all logistics and all support was handled by a very small Proteus staff. The employer eventually requested Proteus test the remaining 65 employees. This was a small operation. 21 of the Latino workers, 8 of the Latino workers were positive. All but the initial worker was asymptomatic. So that gave a 38% positivity rate on at this particular employer. None of the non-Latinos were positive. All the positive workers were isolated, and all the logistics and follow-up were provided by a very small Proteus staff. And it was essentially a 24/7 operation for 2 weeks. So here you can see we're morphing from a primary care clinic to a pandemic response unit. While we're running tests, we wear full PPE, gloves, gowns, respirators. And here you can see we're doing some primary care, checking some blood pressures in the rain. Here we're on a porch doing some blood pressures. And here we're doing some testing in a drive-by testing site at the employer I was actually just speaking of. And here we're doing some testing. And here we're doing some testing at a much larger, more corporate operation. And we've been doing this all summer. We were pretty stunned by the 36% positivity rate, especially since this was a small operation whose workers had just recently arrived, knowing that the state was soon to host thousands more workers, all of whom would be living in crowded settings with very little ability to social distance, and most importantly, with a huge drive to work. This early outbreak of the 36% was completely consistent with what we had been hearing and we continue to hear from other states such as Florida, North Carolina, where they're reporting rates as high as 50% among their farm workers. We can't overestimate the huge challenges facing our workers on this pandemic. Crowded quarters, crowded buses, reluctance to report symptoms, some shortages of PPE, variable ability at testing with long turnaround times, where to isolate, how to isolate, and will screening even be effective among a population that have such a huge drive to work and reluctance to report symptoms, and knowledge gaps on part of growers and workers. The focus on comorbidity is very controversial, and some say it tries to explain away the unique inequities of this pandemic, such as the inability for many Latinos and farm workers and meatpacking workers and other minorities to work from home, shelter, and protect themselves. Some have tried to wave away the disparities by saying, oh, that's all underlying conditions, obesity, diabetes, high blood pressure. People should really take better care of themselves. Well, this is clearly a wholly inadequate and superficial perspective. With all the news, also with all the news of COVID infection among migrant and meatpacking workers, many Latinos in our state and around the country are having to deal with victim blaming and stigmatization. Yet another form of inherent racism in our state and in our country. Just a month ago, IDPH and Workforce Development did come out with a set of recommendations. I want to emphasize they are recommendations, quite comprehensive and inclusive, but very difficult to follow given how the season is already upon us. What we needed was preparation, not last-minute response. So we consider this small Iowa grower outbreak a successful outcome. Successful because we had prompt isolation of the first individual and subsequent infected, prompt request of testing of all migrant and local employees, close follow-up during isolation, all returned to work, healthy, and receptive management to education and further prevention strategies. And really, this led to a collaboration with IDPH, Iowa Workforce Development, Homeland Security, the State Hygienic Lab, and we have half-hour calls every day to think about next steps and the next day. And that's a success. What's next? Well, we're literally building the plane as we fly it. We're continuing to repair and respond, keeping our workers and staff safe. As safe as possible, actually. Using lessons learned and learning wisely, what is working, and to stay nimble. Collecting data with the use of surveys and interviews with the hopes of documenting what we're doing now and informing what we do next. There are several NIH funding opportunities that have come out to look specifically at the COVID pandemic and vulnerable populations. We're actively pursuing some of this funding specifically to look at the social, ethical, and behavioral factors that affect vulnerable populations during the pandemic and other public health emergencies. So what's next? Well, we need to continue to push for change. We need to push for preparation in order to minimize the need to respond. We need to capitalize on the current social and political will for change and the social will for change. We need to seize this window of opportunity to dig down deep and focus finally on meaningful data and the structural and root determinants of racism that enables us to promote equity and ethnic and racial justice. So finally, I want to thank Professor Wing and Colleen for the opportunity to speak. It's really an honor to follow Dr. Washburn and Dean Washburn and dovetail with Dr. Abonye as we dig into these issues together.
So our next presenter here is Dr. Nafisa Abonye. So whenever you're ready, Nafisa, go ahead and join us.
Okay, good afternoon, everyone. I want to start off by thanking the Iowa Center for Human Rights for putting this panel together and for giving me the opportunity to speak about the Blackhawk County Health Department and highlight our equity work. There's so much information, so I'm going to try and go as fast as I can, but please bear with me. I get very passionate about equity and just want to highlight how we've been trying to implement it into practice. So just a brief overview. Blackhawk County has a population of about approximately 131,000 people. It is considered to be the fourth most populous county in Iowa. And the county is a mix of urban and rural, and the racial makeup of the county consists of African Americans, Caucasian, Hispanic, Asian alone, and we have a small population of American Indian and Native Hawaiian and other Pacific Islander. And also in our population, we have the immigrant and refugee population, which make up 5% of the population here in Blackhawk County. The immigrant and refugee population stem from Europe, Asia, Africa, and Americas. And over 40 different languages are spoken in Blackhawk County. In 2018, Waterloo and Cedar Falls, the two largest cities in Blackhawk County, were ranked as the #1 worst city for Black Americans. And the article states, no U.S. metro area has larger social and economic disparities along racial lines than Waterloo, Cedar Falls, Iowa. The Black metro area residents earn just 46.8% of what white area residents earn and are far more likely to be unemployed than white workers in the city. And so this article had really a huge impact on us as community leaders. You can sense the difficulty, the emotional difficulty of us wrapping our heads around this information. Now, this is something that we've always known existed, the health disparities and inequities. However, to be highlighted as the #1 worst city for Black Americans in 2018 really had an impact on the community. So for the health department, sometimes it's important as leaders for us to recognize that how do we utilize negative information like this for the greater good. And so for us, it was first by really digging into the social determinants of health, examining the social determinants of health, which are conditions in the environment in which people born, live, work, play, worship, and age, and look at the data. And in examining the data, we realize that racial inequities looks the same across all sectors of the system. And social economic differences does not explain the racial inequity. Like racial disparity in infant mortality exists when comparing Black and white mothers with the same level of education. So it goes into what Dr. Corwin was talking about, the victim blaming and stigmatization. A lot of times people are like, well, if they just get an education or if they just work harder. But we're seeing racial disparities even among people that have the same level of education, the same level of income. And systems contribute significantly to disparities. So African Americans and Latinos, when you look at the data, we continue to routinely see patterns of denial, for example, within banking. Conventional mortgage loans at rates are far higher when among African Americans and Latinos than their white counterparts. So this is what we would consider modern day redlining. So as a health department, we recognize that we live in a racially structured society, and that is what causes racial inequity within our system. And also the health inequities are not the result of individual choices, it's systemic. So again, that really pushing the communities and sectors to understand that this victim blaming and stigmatization continue to perpetuate the inequities that we see within our system. And I highly recommend individuals that are listening to read the groundwater approach. That's it's what has helped us to frame our health equity approach in the health department. Okay, next slide here. Okay, so the health department, we took on the role as health equity strategists, and we were fortunate to receive the Kresge Foundation's Emerging Leaders in Public Health Award. And this was an award that allows us to implement a transformative approach. So moving away from the traditional role of what health departments are known as just service-oriented, but what kind of role can we play for the community so that we can examine the root causes of the health disparities within our community. So our role is health equity strategist, and the role is to create a community that is resourceful and resilient to transformation, and it believes in the empowerment and solidarity of its residents to achieve optimal health. The health department functions to serve as a resource to partners who are advocating for equity, where we play, work, learn, and worship, advancing unique and culturally sensitive strategies that promote human development and optimal health, and promoting a system of shared community assets to guide the work of local partners to reduce health disparities. So we wanted also to take a systems thinking approach. One of the things that we recognized was that, one, we didn't have a community that understood the social determinants of health. Leadership in all the different sectors were trying to address equity within their particular sector. And we know that when we're siloed, that also allows the system to maintain the inequities. So how can we achieve a common understanding and equity behind language? Like, what is that common understanding? So we took on a systems thinking approach, and we asked our stakeholders what accounts for the level of equity experienced by our community. So what's working to promote equity and what's not working and to promote equity. And what we did was we specifically invited 50 different stakeholders that represent the social determinants of health. And we invited key decision makers because one of the things that as a leader I've recognized is that oftentimes when we have frontline staff that are very much aware of equity because they're the ones that are working with the communities, they don't have also the decision-making approach that we need to take for organizational change. So we specifically wanted people that can implement key organizational change to address equity within our community. So the inhibitors that were identified through this workshop were racism, policy and politics that maintain inequity, entrenched mindset and resistance to change, financial exclusion / poverty, rejection of the other, history / legacy of exclusion, access to mental health and physical health services, fear, lack of support to families and communities. The enablers, what the stakeholders identified that were really good for our community that's working well to promote equity was that, one, quality of education. Our stakeholders thought that we had a very good education system, diversity of the community, presence of coalition and willingness to work together, and a strong economy. So after identifying the enablers and inhibitors, we asked people to create the different loops. And I'll go back a bit here, but loops that were virtuous cycles, stabilizing cycle, vicious cycle, or stagnating cycles. So these are loops to help us identify from a systems approach what would contribute, for example, to quality of education. What would continue? What's a system? What would systems be that would contribute to that quality of education? But what is something that would also affect our quality of education? And so that would be vicious cycle. So in doing that, and this is where here you see the stakeholders putting together the different groups, we created what you call a systems map, the Blackhawk County systems map. So I'm going to zoom out a bit and I'm going to share, can they see the map? I'm going to share this map. So this is what we consider to be our Blackhawk County systems map. And I'm going to zoom in on our deep structure. The deep structure is where the story of Blackhawk County begins. And here you'll see where we have pluses and minuses. So this is showing whether if we take on different approaches, what will happen. Will it promote a certain loop? Will it affect a certain loop? The report, this is a loop that talks about the Waterloo Cedar Falls being the worst place for African Americans. Bear with me. So our deep structure here, I'd like for people to follow me as I read the deep structure loop. Because this is really where stakeholders have identified. This is the story of Blackhawk County, and it's called Divided We Fall. So when groups of people within a community are separated from each other intentionally, uninformed narratives and beliefs about the other persist. This creates an us versus them mentality, which leads to deliberately or unintentionally the selection of sameness. As a result, the inequality in distribution of opportunity and access to resources increases, undermining the ability of the community as a whole to thrive. When some members of a population are doing well while others struggle, it creates a fear. This fear drives people to either hold on to what they have and maintain the status quo, or mistrust a system which has only caused them harm. This fear serves to further accentuate the divide between groups of people within a community, assuring that they never have the opportunity to build awareness of inherent human connection. So COVID, so with that framework, having an understanding that already we are a segregated community, we have an equal opportunity of resources, and we have a fear. There's a fear of people wanting to maintain the status quo, a fear of people struggling and having been oppressed for generations, wanting to really change the system. And so with COVID-19, what it has done, it has highlighted our Blackhawk County systems map. So everything, all the data within our map, it's highlighted, and community leaders are now looking at the map and saying, oh, this what we're seeing, we identify it with this loop, this map. We've already been talking about this. It's here in our community. It's just highlighting. So of the 3,331 cases here that we have in Blackhawk County, when we look at the data from within race and ethnicity, people of color are disproportionately impacted by COVID-19 here in Blackhawk County. This is not the same patterns that we're seeing nationally, statewide. We're seeing it here locally. 5% of the population of color, which make about 17% of the population, overall population in Blackhawk County, are impacted by COVID-19 in comparison to 0.9% of the Caucasian population, which make up about 80% of the population. So we know that the inequities exist. We know that people of color are disproportionately impacted by COVID-19 here in Blackhawk County. So one of the main reasons why we had a really horrible outbreak in one of the meatpacking plants here in Waterloo. The plant we have has about 2,800 employees, and about 50% of those individuals were impacted by COVID-19. And this is a plant that predominantly people of color work in. So we have Asian, African American, Hispanic community, Latinx, community, the people of Burma. So this was really a very, very difficult outbreak, but the health department, in collaboration with our elected officials, did the very best to control for the spread, and also serve the communities that are impacted by COVID. So it's important that we, for the health department, as we continue to address our COVID-19 response, we use a health equity lens. And that requires us to be really engaged with our community. As I stated earlier, we have virtual community forum meetings, with bi-weekly meetings with our community leaders. We're in constant communication with our elected officials, our businesses, the social support services. We've worked closely with Embark, which is a non-for-profit organization that has helped us with our translated materials and videos. And we've also we've done our best, and we continue to work with the community leaders to ensure that we are serving the community to the best of our ability, and also asking their input of what they would like the service to be. So what I've learned, and I'll rush through this really quick, is that when you take on a health equity approach as a health department, it's very difficult. It's not something easy. It requires a change in values, beliefs, roles, relationships, and approaches to work. It's not something that we can solve overnight. And also it requires us to really not have immediate solutions. We have to be able to listen. We have to be able to understand the problem. And so this is what we call at the health department transformative approach. So when we're in conversations or when we're developing programs or initiatives, we ask, is this a transactional approach or is it a transformative approach? And if it is transformative, what is that change going to look like? So I leave you all with this, is that equity work is nonpartisan, but it is political. Equity work requires us to better understand our history and the root causes of the disparities within our community. First Lady Melania stated when she was facing the door of no return is that it is a solemn reminder of a time in our history that should never be forgotten. And President Obama stated, we have to remain vigilant when it comes to the defense of human rights. I thank you all for this opportunity, and please be free to reach out to Black Hawk County Health Department. We have the link for you all that we can share as well. Thank you.
Okay, so just wanted to bring it back for a couple questions. Thank you so much, Dr. Bonnier. So obviously in this session, you all have heard of some pretty stark differences in health with COVID-19 as just one example. And so that leaves us with, how do we identify the systems that are at play that are supporting the status quo, and how do we take apart those systems and change them? And so we have a few questions that have come in that I wanted to share. The recent McGirt decision, will that have an impact on Native communities' ability to respond to COVID-19 by reinforcing sovereignty?
Yeah, no, thank you. Yeah, the McGirt decision by the U.S. Supreme Court, in which the Supreme Court recognized the Muskogee Creek Reservation in eastern Oklahoma. What those kinds of decisions do is they give a place for the tribe to exercise its sovereignty and exercise its regulatory powers and its public health powers. And so that should make a positive difference. The state is there too, and the state has those public health powers, but the McGirt decision will give the tribes more authority to be able to do that as well. So McGirt will be a positive influence for public health in that tribal community.
Thank you. And any thoughts about how this discrepancy in access to health and in health disparities plays out in the prison system and populations? I'm not sure if any of you are familiar with this at all. That was one of the questions.
This is Claudia. I don't know, I don't have expertise in this area at all, but there is, a great equalizer in this population, which is that they are all in the same structural living situation. And it would be interesting to look at how different ethnicities and different groups are affected, because that is a variable that doesn't exist. It takes out that variable. I mean, it would be really interesting to look at how different ethnicities and different people are experiencing this, and if they're experiencing it differently, why?
Yeah. And I would add that, we incarcerate so many more people than most of the rest of the world in the United States. And so a lot of our jails and prisons are overcrowded. And so that just amplifies the problem, because they're already in close quarters. And And that's, it's just really hard to keep people safe when you're jamming them together and the meals are taken together and that sort of thing. So it's a tough environment.
Yeah. And this other question goes deep to the core of what we're talking about here, especially you, Dr. Abonye, and that the person writes, it seems that some communities of color are having to craft pandemic responses on their own. It seems that state and federal governments could do more to coordinate and connect these efforts. What would that look like? And would a lack of trust make that difficult?
So I do think that states and federal governments can definitely do a better job at coordinating their response. One of the things that we've been fortunate for Black Hawk County is that we were engaged with the community before COVID. And that's something very important. That's something that for me, as I stated during our presentation, I'm very fortunate to have a deputy director that can run the operations of the health department. But I had to, as a leader, go into those communities. I didn't want to hear from staff necessarily, not that I don't trust, I trust them, but they also needed to see me and how I value them. And it's a mutual relationship, right? So I think for us, that was very beneficial. Community leaders have my number on speed dial. I said, whatever's happening in your community, if you cannot get a hold of anybody at the health department, you call me. And I think, so that's what made our response, even when the outbreak was occurring at the meatpacking plant, I had community leaders calling and saying, there is a crisis. There is a crisis. We don't understand what's going on, but something is going on, and the health department needs to be aware. And so, and even with the business community, I think oftentimes public health is seen as enforcement, but this was an opportunity for us to be educators, and understanding people's values or organizational values and how they align with public health has been very key with our response. And so it's unfortunate that other communities are having to have their own response plan, but I really, for us, it's the responsibility of the health department, and it does require us to engage differently. And that engagement, we're working with the community. So we really are engaged, immersed. We have meetings where they tell us, also they inform us what are the best strategies for their communities. I mean, I think that's the main thing, and that's what empowerment looks like for my perspective.
This is Claudia. Just to follow up on that, Dr. Abonye, we're not done. So once, vaccine is on its way, and if we thought testing, masks, social distancing was difficult, vaccination is going to be so much more complicated. And that's something that if we're successful in our application, we'll be looking at the trust, credibility, the ethical, the moral, the behavioral aspects of messaging and adaptation and adoption of public health strategies, because we have such a complicated history with respect to medical intervention. And I think, and it's my experience just in my own personal life, this reluctance is not going to be purely stratified according to economics or class within the vulnerable or minority populations. I think it's going to be prevalent, the reluctance to get vaccinated, irrespective of education, of economics. I think it is going to be very, very difficult. And if we don't start to strategize on how to reach populations in a responsible way, we're going to have a lot of trouble.
Mm-hmm.
So on that note,
Upbeat note,
I want to remind people, as Dr. Corwin has stated, to seize this window of opportunity to address structural racism at its root. And you don't have to be a health practitioner or a researcher or scholar to do that. You can put pressure on those systems
every day.
Everyone who has decision-making power can feel that pressure for change. So thank you again, and you can access this webinar and our previous ones on our website at uichr.org. Thank you so much.
Thank you. Thank you.
Thank you.